Greetings and welcome to today's presentation titled CCBHCs and Crisis Response Services for Children, Youth, and Families. Before we begin, we would like to remind you that this is a safe and friendly space for positivity and productivity. There are a few housekeeping items that I'd like to quickly go over. This presentation is being recorded, and the recording link, slides, and a certificate of attendance will be sent via email to everyone who attended today. This information will also be available on the National Council's website and NASHBID's YouTube channel. Please use the chat pod to share your name and state, ask any questions, and or share any information with the group that pertains to this presentation. Closed captioning can be viewed by clicking the CC at the bottom of your screen or clicking the link in the chat pod to view in a separate window. We also have an ASL interpreter who is spotlit on your screen. When the presentation ends and you leave the meeting, there will be a brief survey that will show in your browser. Please take a few moments to share your comments and thoughts with us about today's presentation. We would like to give special thanks to Samantha for sponsoring the presentation today. And again, thank you for joining us. I will now turn this over to Sam Holcomb from the National Council. Thank you all. Thanks, Sam.
Thank you so much. I think we can skip forward maybe 2 slides. The next slide and one more. Great, wonderful. Well, welcome everyone. I'm so happy to see so many people joining and the numbers keep going up, which means hopefully you all had a good long weekend and had some restfulness and are now back to it and are here to learn with us today. To just briefly introduce myself, although I see quite a few familiar names on the line, I also see a lot of names I'm not as familiar with. So hopefully a lot of new audiences here to the CCBHC model. I'm Sam Holcomb. I'm a senior director at the National Council for Mental Wellbeing, where I oversee our CCBHC programming that supports clinic implementation of the model. So that happens in a few ways. I serve as the project director for the CCBHC expansion grantee National Training and Technical Assistance Center, which is funded by SAMHSA. And many of you might know me from that. And then I also oversee any other types of supports or programming that we do for clinics and states to support spread and implementation of the model successfully. So what I'm going to do today is start with a little grounding, assuming that not everyone is coming in on the same page of what a CCBHC is and what their knowledge of the model is. And then I'm going to turn it over to my esteemed colleagues in Oklahoma. They are really going to bring it home to give you a picture of what this looks like in practice when it's done really, really well. And they are here because they do this very, very well. So just as a starting point with something as basic as what is a CCBHC, which stands for Certified Community Behavioral Health Clinic. So this is an integrated and sustainably financed model for behavioral health care delivery. And it really was designed to alleviate challenges that we often see that have led to a crisis in providing access to mental health and substance use care across the country. So CCBHCs, are designed to ensure access to integrated evidence-based addiction and mental health services that includes 24/7 crisis response. They have stringent criteria that they need to meet regarding timeliness of access to care, staffing, coordination of care with social services, criminal justice, education, and other systems. So really thinking about coordination to ensure whole person care. And then they receive funding to support the real costs of expanding services to fully meet the need for care in their communities. And within all of this, the model has a lot of criteria that we will talk about. But at its core, it's community focused. And so all CCBHCs are required to do a community needs assessment and think about the requirements of the model and how they can be designed for the unique needs of their community in mind. In addition, and I think most importantly, the CCBHC model is designed so that CCBHCs are required to serve all agents and all individuals, regardless of their location and ability to pay. So it's really thinking about how do we break down the barriers to individuals being able to access the supports they need. Next slide, please. So I won't go too deep into this because we could have an entire webinar itself on the funding pathways for CCBHCs, and we have a lot of resources that can really walk you through this. But I do think it's important to set the context in terms of what this is, how it's being funded, and what we're seeing across the country, right? So currently there's 3 funding pathways for CCBHCs. There is the original CCBHC demonstration program. So this was a CMS demonstration established in 2017. It's now being operated in 8 states. And within those states, the states had the opportunity to establish a program, which is overseen by the state and allows state certification for eligible clinics utilizing the federal CCBHC criteria, which I will talk a little bit about. And those clinics get an enhanced Medicaid payment called a prospective payment. Increasingly, we're starting to see some states who may not be waiting for the demonstration to open, although there has been recent legislation in the last year that has paved the pathway for the demonstration to be expanded ultimately to all states if they so choose to over coming years, allowing for more and more states to join every 2 years. But some states have chosen to take an independent state Medicaid funded route to the program. So there's states who have leveraged Medicaid state plan amendments or 1115 waivers to establish similar processes for a state certification and selecting and certifying clinics within their states to meet eligibility criteria for CCBHCs and get an enhanced payment rate. And then finally, what many of you are probably most familiar, because this is a majority of the clinics right now who are operating as CCBHCs, is in 2018, SAMHSA started administering a CCBHC grant funded program. So within this program, SAMHSA awards grant funding directly to clinics to support adoption and implementation of the model. And so what I'd largely say about that program is it's important to kind of just understand grant recipients are not necessarily certified by their state, either because the state does not certify CCBHCs, so doesn't have a mechanism for that yet, or because they have just not yet received certification from their state. And so those grantees actually must attest to SAMHSA that they are meeting the CCBHC criteria requirements. And we tend to think of this as a pathway for building capacity towards CCBHC certification and true implementation should it become available as a sustainably funded program within their state. Although we also see many states, there are clinics who are in demonstration states who utilize this funding to continue to build and enhance what they're already doing within their CCBHC programming. And just drawing your attention to this little icon on the right side, what you see is just the incredible growth and spread of this program over the past 5+ years now, which I imagine is why so many of you are on the line right now. You're hearing more about CCBHCs, you're maybe engaging with them or have recently become one or exploring the option of becoming one. And we're really seeing this as a massive change and transformation within our behavioral health system nationally, looking at going from those 8 original demonstration states and 66 clinics in 2017 to over 500 clinics who have some sort of CCBHC funding right now. Next slide. So the CCBHC program requirements, there is 6 key areas in which clinics have to demonstrate their competencies. And I will do a high-level overview, but you can also feel free to do a deeper dive within the actual outlined criteria itself. That is a 60-page document with really detailed implementation guidelines. And the National Council also has brief on-demand videos on our website that break down the requirements and implementation considerations if you want to go a little deeper into these. But that includes staffing. So those staffing standards need to be informed by local needs. Availability and accessibility of services. So there is standards that CCBHCs have for timely and meaningful access to services, for outreach and engagement, and particularly around really timely 24/7 access to crisis services. There is requirements around care coordination, which services and providers and infrastructures must be set up as a CCBHC to coordinate care for individuals being served. The scope of services I'll get back to in 1 second. There's also quality and other reporting. So there are quality measures and quality improvement requirements that CCBHCs must report on and adhere to. Organizational authority and government. So that's thinking about consumer representation in governments and appropriate state accreditation. And those 9 required services, you see them on the right-hand side of this slide. These are the services that CCBHCs must be providing. We'll talk a little bit more about some flexibilities and what those services look like and how they can be provided. But the idea here is really serving as a home for an individual so that all of their needs within behavioral health can be met by the CCBHC, and it feels seamless, it feels integrated, it's breaking down those silos that we typically, unfortunately, experience in delivery of care, and that walking into a CCBHC, an individual understands fully what services they can access through that CCBHC. Next slide. Okay. So teeing this up for today, I'm going to do 2 things. I'm going to talk specifically about within the criteria, what the considerations are for children, youth, and families. And then we'll talk a little bit more about the crisis requirements within the CCBHC model as well. So looking at these on the left-hand side, we have the criteria areas, and then on the right-hand side, key elements with children's focuses within this. So starting first and foremost with that organizational authority, the focus of the CCBHC model is that we are really shifting towards a person-centered model to centering voices of lived and living experience. And so the CCBHCs are required to meaningfully have participation from individuals with lived and living experience and their families. That includes youth. And that participation needs to be designed to assure that the perspectives of the people receiving services and families are integrated in leadership and decision-making across the organization. So it's really thinking about how you elevate the voices of all individuals, including youth and their families, in developing initiatives, in identifying community needs and goals and objectives, and informing the staffing model and the service development, and being part of continuous quality improvement. Within staffing, so the CCBHC staffing plan needs to both meet the requirements of their state behavioral health authorities and any accreditation standards required by the state. But then again, it needs to be informed by the community needs assessment and appropriate to addressing the needs of people receiving services at the CCBHC. So for those running state programs, the state has the autonomy to kind of specify disciplines required for certification, but there are bare minimums in terms of what the CCBHC staff must include. And when thinking about needs for children and families, that includes individuals with expertise in addressing trauma and promoting the recovery of children and adolescents with serious emotional disturbance and substance use disorders. In terms of availability and accessibility standards, so this is really thinking beyond, the 4 walls of a clinic, really. There's a lot of flexibilities allowed for CCBHCs in thinking through how to develop access that is really at times and places convenient to those served, and providing prompt intake and engagement in services. And so when thinking about children, youth, and families, it's thinking about, okay, where are these services best received? Is it in the home? Is it in the school? And allowing for those flexibilities in design of service delivery to account for that. Next slide. So then within scope of services, we looked at those 9 core services, right? And I think the key element here is really thinking about as CCBHCs are designing their service delivery model, they're thinking about how to utilize the needs assessment to understand who has the greatest need within their community and which evidence-based practices and other services they deliver. They need to be specifically considering what is appropriate for children, adolescents, transition-age youth, and they must provide evidence-based services that are developmentally appropriate, youth-guided, and family and caregiver-driven. Care coordination is the linchpin of this model. And when talking about children, youth, and families, you have to really define care coordination outside of intensive care coordination and wraparound, which is obviously an evidence-based practice and service. So within the CCBHC criteria, it's really defined as deliberately organizing an individual's care activities and sharing information among all of the participants concerned with an individual's care to achieve safer and more effective care. So CCBHCs, when it comes to children's, youth, and families, are required to coordinate care across settings and providers to ensure seamless transition. And that includes some of the partnerships and coordination agreements that they need to have called out here, right? So that includes thinking about schools, child welfare agencies, juvenile and criminal justice agencies and facilities, child placing agencies for therapeutic foster care services. And they really have to have policies and procedures to assist individuals and families of children and adolescents in obtaining appointments and keeping appointments when there is a referral to an outside provider. And they have to have an interdisciplinary treatment team that's really responsible with the individual or the family or caregiver for directing and coordinating and managing care and services for that individual. And I think you'll really see that in practice when our partners at Grand present later. Moving quickly to CCBHCs and crisis services, which is the intersection of all the things that we're talking about today, right? Children, youth, and families. If we go to the next slide, there's 3 key elements of the CCBHC crisis requirements. And if you look at them on this slide, they really do align well, if you look at the blue below, with SAMHSA's national guidelines for child and youth behavioral health crisis care, which I know Sheamekah is going to talk about more. So these core components being emergency crisis intervention services, that's that someone to talk to. The CCBHC, has actual implementation requirements around providing or coordinating with telephonic, text, and chat and crisis interventions and call centers that meet 988 suicide and crisis lifeline standards. And they have to participate in any state, regional, or local systems which provide quality coordination of crisis care in real time, as well as any service capacity registers as appropriate. 24/7 mobile crisis teams, so that's someone to respond. So the CCBHC must provide community-based behavioral health crisis intervention services using mobile crisis teams 24 hours a day, 7 days per week, to adults, children, youth, and families anywhere within the service area, including at home, work, or anywhere else the crisis is experienced, right? And they are expected to arrive in person within 1 hour. There's some flexibilities with that within rural and frontier settings from the time they are dispatched. And then finally, crisis receiving and stabilization. So that's a safe place to be, right? The CCBHC provides crisis receiving and stabilization services that have to include at minimum urgent care, walk-in mental health and substance use disorder services for individuals. And they need to be able to identify an individual's immediate needs, de-escalate crisis, and connect them to a safe and least restrictive setting for ongoing care. What I want to say within all of this is that that blue box at the top is critical. Every system and community is different. The criteria sets a minimum set of standards, but there is a lot of gray area and flexibility within that for the clinics themselves, as well as the state, to really work collaboratively and understanding the context of their own systems and communities and designing the right crisis interventions and services that don't duplicate existing services or supports, but really accentuate them and complement them. And so that looks very different by state, and you'll hear in detail from Oklahoma today what it looks like in their state. but really want to re-emphasize that because, the CCBHCs, although they need to directly provide those non-core services, there is flexibility through what we call designated collaborating organization agreements to perhaps work alongside existing state-sanctioned, certified, or licensed systems or networks so that they're not duplicating, but really thinking about that full continuum of crisis needs and how we are developing a system in which the CCBHC is able to fill in the gaps and wrap around it. So I'm going to stop there, and I'm actually going to turn it over to Sheamekah Williams, who is the Director of Children, Youth, and Family Services with the Oklahoma Department of Mental Health and Substance Use Services. She's going to talk about, national guidance and then really get into how this works in Oklahoma.
Thank you, Sam. As Sam mentioned, I'm Sheamekah Williams, the Director of Children, Youth, and Family Services in the state of Oklahoma. And I want to share one state example of mobile response and stabilization services and how we got there. But I really want to talk about some national documents that will be really helpful and useful for states or communities that are really structuring to move in the direction of CCBHCs, as well as mobile response and stabilization for kids. Next slide, please. This first document is the National Guidelines for Children and Youth with the Behavioral Health Crisis Center. This document was put out by SAMHSA this year. It talks a lot about someone to talk to, creating crisis centers that are 24/7, 365 days. Again, if you're really thinking about this from the perspective of parents, oftentimes when we have situations where we don't have the resources or the skills in order to de-escalate or to really keep our kids safe, we need a place to go. This right here, someone to respond to call centers, would really be a point in helping to direct families away from emergency rooms and those type of environments. What we want families to be able to do is contact us and really help allow our call centers to really talk through the appropriate direction for psychiatric emergencies. Someone to respond, mobile response teams for children, youth, and families. Again, I'm going to say this as my colleague Liz Manley would say, just go. Families want people to just come to them or go to them when in fact they're in crisis. I mean, imagine having a young person and you don't know which direction to go and they're having a psychiatric emergency. And oftentimes that ability to be present with the family, to talk through the process can be extremely helpful. So in a mobile response and stabilization system, we want providers to just go and really be a part of talking with the families and really helping to address the problematic issues that are coming up with families and young people. And a safe place to be, crisis receiving and stabilization services. Again, this is quite different and looks a little different when it comes to children and families. Ultimately, what we know is young people are more productive when they're at home in their community and they're safe. And so really when we look at a safe place to be, it's really not higher levels of hospitalization. We often know that young people sometimes need hospitalization, but at the least, we want to look at those least restrictive environments and those creative environments and approaches that we can provide in order to maintain and keep young people at home. You will see some examples of this as Gran talks directly after me. Next slide, please. This next document is also talking about a safe place to be. What we don't want to do is create a crisis response system that looks like an adult model or adult system. We know that young people are different. Young people are in the context of families, and often families are involved or caregivers are involved in their care. And so really recreating an adult model is really not sufficient for young people 0 up to the age of 25. And I say up to 25 because we have transition age youth that are still in the care of a caregiver or a parent. And so we want to create models that are really specific to children and families. Also, 988 has provided a great opportunity and really a great streamline and a process for youth and families that are experiencing crisis. But it's also important to provide these services that are equitable and responsive to the diverse populations as we talk to young people, really looking at different populations, where they're talking about Native families, where we're talking about African-American families, and really looking at families as a whole, and how do we really create an opportunity to respond to diverse populations within your state or within your community. Crisis stabilization services should be services that are really upscale for the purpose of really working to stabilize those families. As Sam mentioned earlier, high fidelity wraparound services and home supports are great services to help families to stabilize, but making sure that from the point of crisis, we're not done. There's a continuation of that we have to be able to establish, and we have to be able to develop in order to keep families at the lowest level of care, not utilizing those high-end services when in fact their crisis can be resolved or de-escalated or diverted at lower levels. And then also stabilization services are extremely important. They're grounded in systems of care values and principles. There's a link specifically to this document at the end of the slide. And really those values and principles help providers and community to really look at the core elements that is needed to interface with children and families. And we'll talk about those here in a minute. Next slide, please. This document that's referenced on here is making a case for comprehensive children's crisis continuum of services. And it's really important to think about that because we're not just talking about crisis services, that mobile response. We're really looking at how do you begin to build out the entire continuum from preventative type, creating pathways for intervention, whether they're pathways with your education systems and schools, whether those pathways are with specific diverse communities like Black and Brown young people that are in the community, or really creating pathways for juvenile justice as well as families that are involved in the child welfare system. It's important in this design to really look at upstream interventions. And what I mean by that is oftentimes families call when they need help. And if we're able to help them then, it is likely that we won't go into those higher end psychiatric behaviors that really create stabilization to happen at the hospital level. And so again, it goes back to that when in fact families call, we need to go now. We also need to consider meeting youth and families where they are and really allowing them to articulate the problems or the issues that they see, or even the behaviors, and really looking at measures of de-escalation and diversion, and really looking at more before we need more restrictive environments. Again, there's always a point where we can intervene and really stabilize at the local or community level. And then also ensuring the connection to the necessary services and supports. I mean, most of you guys know that when COVID hit, there were a lot of different families that were in need of crisis. But again, crises are defined by the families. And sometimes crisis can escalate from situations where families don't have their basic needs met. And so how do we begin to intervene early in order to look at how do we help these families to stabilize, and so we don't have those hiring services. And then also key services that are shifted, often sometimes overused. I mean, most of us know that, I'm a parent, and when in fact I need help, I want help now. And sometimes the emergency room is often seen as that place where help can be provided. But ultimately, what we want to do is shift to not just the physical health or a medical emergency room. We want to shift to a model of mobile response and stabilization to look at how do we address psychiatric needs more so, and to be more specific. Next slide. And so this slide is going to go into just the minimum, the basic things that are really needed to set up a mobile response and stabilization system for children and families. And again, we're talking about the availability. So making sure that the call center and the staff are 24/7, 365. Face-to-face within 1 hour, that is a standard. What we want providers to do is just go to meet those families where they are in the community, in the homes, to provide that face-to-face intervention. I can't explain how important often when you're in crisis or when you're going through a traumatic incident, that a warm body can be significant. Workforce that are trained specifically to respond to children, youth, and families. Again, this is really important. You want workforce to be able to address not just the individual, but the entire family. Because like I mentioned, oftentimes, on the adult model, we're working with individuals. In the children's model, we're working with, in my sense, I believe it's a team of people, the caregiver. Sometimes it may be other family members that are involved. to really help them to understand the importance of really stabilizing the crisis and working through the crisis so that we can keep those young people at lower levels of care. And then also support occurs in the home and in the community. You know, I don't know about you guys, but when I was growing up, it took a village, and the same concept is the same today. It takes a village to raise a child. So it's really important to look at those unique things that are not only happening in the family, but the community, to make those connections for families, to assist us and aid us into stabilizing in the stabilizing care. And then one that I mentioned earlier is callers know what they need, why they need, and how it needs to be delivered. Again, we have to work with parents and caregivers to really understand what that needs to look like and really customize individual level interventions to work with children, youth, and families at the community level. Next slide, please. Again, I want to credit the University of Connecticut Quality Learning Collaborative for mobile response and stabilization on this. This is the MRSS continuum, and it talks about the someone to talk to, someone to respond, and a safe place to be. This is really about creating an access point and creating a mobile response and stabilization system that not only works just for the response, but really what that 72 hours needs to look like. And within that 72 hours, you're linking families to community connections and support. You're providing that peer support. You're following up with these families in order to maintain the level of safety. You're connecting them to the community resources, but also connecting them to your CCBHCs for that continuation and that full continuum of care of support and services that they're going to need to have. Again, you'll see the different things that are important in MRSS. Like I mentioned, in-home interventions, care coordination, crisis response, and most important, creating that access point. Within this continuum, you're looking at opportunities for respite care. You're looking at those safe places to be. There are times when families and young people have to be separated for the purpose for a short period of time. And I do mean short period of time because you want to work on really not just stabilizing the young person, but stabilizing the caregiver and the parent. And what I mean by that is really helping that caregiver and parent, not just to understand the means of the crisis, but to really understand how do you work to prevent these types of things from happening in the future. And so it's really important to do that. And then also psychiatric consults, really, you're talking about your psychiatrists, you're talking about those individuals that have the ability to intervene and address medication issues and other issues. And then also technology is important as a part of that. You know, in Oklahoma, we are rural and frontier, so technology comes in extremely helpful. Next slide, please. This right here talks about grounding these systems of care values. And it talks about the rapid response that are needed for communities and in-home supports. It also talks about how you develop and customize these services and supports to really model what's needed for children, youth, and families and young adults, and really not modeling after the adult system. We also talk about the importance of embedding with the full spectrum of effective services and supports that really helps to minimize the risk for behavior and emotional challenges. You know, this can be a combination of trained staff who know how to work within that, but then also a spectrum of services and supports that are specifically designed to help with the behavioral health and emotional challenges that young people face. MRSS is designed to really work with the child, the family, as well as the young person. It is also designed to really be a point to respond to children that are in schools, crisis system, child welfare, and really look at those early opportunities for early intervention within the juvenile justice system. We know that oftentimes we've heard that slogan, pipeline to prison for youth that are really struggling in the school system. So this is an opportunity to derail that process and work with those young people that are really having challenges and preventing them from going further and further into the criminal justice system. And then also the importance of engaging informal supports within the care planning process. You know, I call it the 3 F's, faith, family, and friends. And there's a place for those people at the table. Those are the people that we use on a regular basis to provide support to us in a healthy family network. And so it's important to create those opportunities for young people that are really struggling with mental health. Next slide, please. I also mentioned the importance of grounding in values and principles. Again, our mobile response and stabilization teams should really understand the importance of family and youth-driven care. They should also understand the really cultural humility and linguistic competence, and then how to be trauma responsive. I mean, we don't want to re-trigger young people that we're responding to. As an example, any opportunity that we have to respond without the intervention of law enforcement, when we're able to keep families and young people safe, we should do that. We should only utilize those more restrictive things when in fact there is safety and other things that are at hand. And then also making sure your system is data-driven as well as outcome-oriented. Looking at the data, what are the facts? What does the data in your state tell you about this population? Why do you need these types of mobile response effort? How do you know it's effective? How do you know it's working? And those things are going to be important. Next slide, please. I'm going to go into specifics about the home, and I'm going to do that. I want to definitely hand it over to my colleagues at Grand. But this next slide really talks about, next slide, please. This next slide, again, kudos to the University of Connecticut, someone to talk to really in the MRSS model. We know that 988 began in July 16 for us in 2022, but MRSS began 5 years before that. We had a mobile response and stabilization system in the state of Oklahoma that's responding to young people. And so really what our job is to really connect those dots from 988 when in fact a young person provides 988. Our response system in our state, we're expected for kids to do mobile response, not just crisis response, and really looking at how do we intervene as early as possible to get to those youth and families. And then also our crisis system is not defined by our system, it's really defined by the caller. Oftentimes families will call in crisis and it may not look like what we see as a psychiatric crisis for in our field of work, but it may look like, you know, a young person is really struggling to maintain going to school. A young person is really having high levels of depression, anxiety. It may look in a different way. A young person is running away, but if the opportunity to respond as quickly as possible may mean that we can keep those young people out of those higher levels of care and really look at what's causing some of these problematic behaviors and divert those young people to more least restrictive opportunities, such as outpatient high fidelity wraparound care coordination outfits that provide intensive in-home services and supports. And then ultimately, we should always provide a warm handoff from the call center to the mobile. There's nothing like a drop call, and there's nothing like the opportunity to engage with the person that's going to be able to provide the response, and our call centers do that, making sure that families stay connected from the time that they call to the time that they're talking to the person that's going to provide the response. Very important. Next slide, please. Also, someone to respond. I talked about the 24/7. Again, mobile response for youth within their own home and community, and also looking at opportunities, not just to assess the situation. Is there ability to de-escalate? Can we look at how, and can we look at how do we maintain families in their own living environment that they're accustomed to? How do we de-escalate and divert those opportunities? How do we make sure there's a safety plan in place? You know, one of the things that Oklahoma is a big gun state. We have young people that hunt and have rifles and all those things. You know, what are some interventions in our state? Again, if we can provide gun locks, or if we can work with families to lock those things up, maybe there's an opportunity to divert and keep that young person in the home with a crisis and stabilization plan, as long as the families are involved in really supporting that. And really moving away from ED in young people and really allowing families to determine and decide what's best for them in an environment that's safe. And making sure that we're following up to make sure that our young people get what they need to get connected to the community services and supports, to maintain connections with our CCBHCs so that their behavioral health needs can be met is really important in that follow-up. Next slide, please. Again, I mentioned a safe place to be as a CCBHC. Our CCBHCs have high fidelity wraparound, which is one of the highest levels of service you can receive. In addition to in-home therapeutic services, therapy services, peer supports are really important when you're working with families and caregivers. I mean, what better opportunity to have an individual that has been there and done that to interface with you to help you to walk through this process. Embedded school-based services, medication management, and also looking at wellness, really looking at everything from a checkup from the neck up, but then also looking at their overall body and that overall connection to some of your other healthcare concerns like diabetes and how it relates to depression. So wellness as a whole is really important in a CCBHC. Next slide, please. Again, these are some data matrix, and I'm gonna run through these quickly for the purpose of time. Really looking at process managers that allow you to look at the calls, the abandonment of calls, when in fact they're not answered. These are things that your call center should be able to collect. In addition to that, you also want to know if the individuals that are calling, have they been satisfied? Did they get what they need from that experience? And so really setting up your call centers to be successful. Next slide. This slide right here is really process measures around mobile response, really looking at the demographics of your young people, really looking at a combination of assistance with program planning, whether we're talking about staffing, dates and times that are really more high volume of calls, the response type, is there a warm handoff, were they deferred, was law enforcement involved, so that you can look at the general population and really begin to look at those pathways and really customize your system to meet the needs of all. And then also a reason for the call. It's important for us to know if our young people were this was violent behavior, what was taking place. And then outcome measures. You want to know, what's the stabilization provided? What were you able to look at, not just stabilization and placement, but school stabilization? Keeping young people in school is extremely important. And then, as I mentioned earlier, the satisfactory of the MRSS as well as the call center is really important. And then the youth progress, we're able to look at youth that come into care with our CCBHCs to look at their full spectrum from crisis all the way through the continuum of care. Next slide, please. I'm going to go into some specific data points. You can go to the next slide. This is data that I'm going to share that, again, through COVID. Again, in the state of Oklahoma, we're able to look at our data based on county data. We're able to look at based on provider in order to help providers to determine staffing patterns, to help providers to determine if crises are coming from a particular population so that they can intervene, or if crises are coming from kids that may be going to the same school, and so they can really reach out and make connections in those school systems. I mean, it's also important for us to know what our volume is looking like. Are there certain areas that we haven't done major outreach in that we need to get at? So again, this digs deep into our data collection that we have from the call center all the way through from the response, from the call to the response. Next slide. As I mentioned, we're able to look at days of the week, times of the day. I mean, we know that oftentimes during that peak time when kids get out of school up until their bedtime, that is a high volume time where we get a lot more crisis calls. As you can see, some of the hotspot areas really help us to project days of the week, certain time periods, so that we can navigate and adjust across our state in order to be able to meet the needs of our population. So this is some of our hotspot data collection information. Next slide. I mentioned today's response time and date. That was something I mentioned, so I'm going to slide through that slide. You guys will get these slides. So we'll go to the next slide. One of the things that I'm extremely proud about in the state of Oklahoma, we have about currently right now an 83% diversion rate. That means if our young people come in contact with our mobile response system, 83% diversion. That means we're able to keep young people at home and in their communities safe. And again, not interrupt that environment, not hospitalize our kids and not put them, again, experiencing additional trauma. In addition to that, if we're talking about school diversion, the provider that you're going to hear next, I mean, their school diversion rate is around 87 to 90% diversion. That means if they get to kids in school, they're able to keep kids in school or return to the school to very next. So it's really important for really looking at that pathway as it relates to school intervention. Next slide. And again, this is some more data points specifically around what we learned through COVID as it relates to age population and really how, again, within that 6 months COVID process, how our transition age youth, how they done through COVID and what those call volumes were like and how they went down and how they went up at certain peak times. Next slide, please. And this last slide really is an example of an unintended, we had no idea that mobile response was going to definitely help us to look at stability and living situation with our transition age youth. Whether we're talking about our young people that were homeless, we were able to identify, and homeless is definitely a point where we were able to intervene and creatively strategize around ways to help our transition age youth to maintain housing. This particular data really talks about certain time periods and age groups and the percentages of young people within our system that really were calling through our crisis line and aiding us in help, and how we were able to move them from a point of instability to stabilization. Next slide, please. And again, here's some great resources that you can connect to specifically around Oklahoma mobile response and stabilization. But I'm not going to further ado, because the next presenters, Josh Cantwell and Larry Smith from Grand Mental Health, will show you some extraordinary examples of really how their organization as a CCBHC has really been able to look at that, someone to respond, but also a safe place, and really develop a children's youth and family system that is really specific to the design of children and youth. So Larry and Josh, I will turn it over to you guys. Thank you.
Sheamekah, thank you very much. Can we go ahead and advance to that next slide? Hello, my name is Josh Cantwell. I'm the Chief Operating Officer at Grand Mental Health Center. So we represent a certified community behavioral health clinic in 12 northeastern and north central counties. That's about 10,000 square miles, primarily rural, serving an overall population of around 490,000 individuals. Larry, would you like to introduce yourself?
Yeah, my name is Larry Smith. I'm the CEO of Grand Mental Health. You're going to hear us talk a lot about what Sheamekah looked at models, and we're going to show you how we have done some of the things that Sheamekah is saying that we should do in order to treat children in a least restrictive environment. I'm really excited about being here. I hope everyone had a great Memorial Day weekend, a safe one, and enjoyed yourselves. And we're all back to work now, and we're busy. So we're going to be talking about some different programs that we put in place and some of the outcomes of that. Next slide, please. You know, our mobile crisis, we have mobile crisis teams that go out, our mobile crisis was created through what Sheamekah just talked about, Department of Mental Health, Terry Slatton Hodges, our commissioner of the Department of Mental Health, and their support of all this is what made it possible. But we have community partners, including the Department of Human Services, hospitals, law enforcement, schools, and we have access to immediate crisis response 24/7 via an iPad equipped with the MyCare app or a crisis line that we provide. And our mobile crisis teams and our mobile crisis through the iPads is how we do immediate response 24/7 to anyone and everyone in the community. We have an iPad at every hospital, so if a family comes in, they'd be able to contact our crisis center immediately, and we could send a crisis team out to the hospital. Law enforcement also has our iPads in all their vehicles, around 980 of them. Police officers in our 12 counties, and everyone has an iPad in their police car that can contact immediately with an LMHP or our crisis teams and immediately respond to any situation that's out there. A significant decrease in wait time is what we're looking for. When you have 10,000 square miles to cover, and you don't have the funding to have a crisis team in every community, it means that time can get into an hour pretty easily. So the decrease in waiting time for crisis response leads to a safer and more positive outcome for the child in the community. And so the quicker we can respond, we're finding that the less trauma is going to happen before we do intervene, which makes it easier for us to deliver our services and get the situation under control. In the school settings, we utilize behavioral health coaches for meeting with students and families that have identified a current behavioral crisis center. We have a behavioral health coach in almost every school in our 12 counties. And then we have on-site therapist support is always provided when necessary in the school. So a lot of crises are happening in the school. Like Sheamekah said, right after school, many times it's at breakfast time. Times when families interact is when you're going to have a need to have a crisis team or are being able to mobilize very quickly and to come in and to start resolving a crisis situation. So this is just the outline of it. Josh, you want to add some stuff to this? I know you have a lot to add.
I do. So if Larry and I are successful with our part of this presentation today, we're going to be able to paint a picture for you of our part in kind of, implementing what the state and what the CCBHC model has laid the framework for. So for us, it all starts with this idea of unbridled access to care before, during, and after a crisis. And what we're talking about with that is we know that there's multiple ways that people come in contact with the system when a crisis is occurring. And we know that some of those ways are lead to a higher chance that a higher level of care is going to be accessed. For example, we know that if a family makes it to an emergency department, the likelihood of an inpatient stay occurring is much greater than if we can intervene prior to them making it to that emergency department. That's the reason that we've created this network of this unbridled access, because what we're looking at is the places where people could seek assistance. And so for us, law enforcement was that first one. We know that many times law enforcement was involved when a situation escalated towards a crisis situation. And so for us, law enforcement didn't have too many other options than going to the emergency department. We had to stop that. We had really strong successes with a similar model with adults, and we knew that if we could get the iPad in the hands of law enforcement, see, because when they hit the button, the use is so simple. There's a button, it's in single app mode. When they open the device, it's alive. They hit that button connects them to a live licensed behavioral health professional that's at one of our 4 24/7 crisis centers. So it's someone that's awake, alert, and providing treatment at one of those centers, has specific training with children's crisis response, but they're able to handle that call, provide the law enforcement officer with information, then talk directly to the family or the client to start that process. So like Sheamekah and Larry said, if we need to send somebody out in person, then they're on their way, but it may be 30 minutes, it may be an hour, but we're already providing a clinical service via that telemedicine response. So we're already helping to resolve that, because the second part of what we're going to talk about is this rapid involvement. The sooner that we can become involved in this crisis, we know the more likely that we're going to be able to resolve it with a level of care that is not that highest level of care. We also are always looking for treatment in that least restrictive environment. We're going to talk about some of the gaps that we filled, because that's one of the main things that we had to look at. Is previously we had a couple options. We had outpatient services, we had inpatient services. That was not meeting the mark. So throughout the rest of our portion of the presentation, hopefully we're going to be able to share some of those other gaps that we filled. Next slide, please. One of the gaps that we're talking about came from our thinking about a problem that we were seeing in all of our communities, but one community in particular, in Bartlesville, Oklahoma, we were seeing a disproportionate amount of kids going both to inpatient hospitalization and into the foster care system. So we knew that we had to come up with another option. See, it's great that we have an ability for people to call our 24/7, crisis hotline and have therapy take place. But what are we going to do with people that may be in a situation where they're edging towards that higher level of care need, or they're in that level right in between where outpatient just isn't enough, but inpatient may be too, or residential treatment may be too excessive? We had to come up with something different. So what we did was, with the goal of decreasing the number of children that were being removed from the home, we looked at some of the evidence-based practices that we were having some successes with. So high fidelity RAP, and then parent-child interaction therapy. And so for those of you that aren't familiar with parent-child interaction therapy, it's where we have people, you have a two-way mirror, and families will come in for a session and they'll practice, they'll communicate with their kids. And during that time, we're watching them through the mirror, and we're talking to them in an earpiece, and we can help give prompts. So what we can do is we can train on ways to better interact. We can actually model that behavior. They can practice the behavior for us, and then we can give them real-time opportunities to implement some of those new ways of interacting that they've learned. And so in a therapeutic setting, like a traditional clinic setting, that may occur a couple times a week for an hour and a half at a time. Well, we decided that we were gonna build a house that was dedicated to that type of service. So we built a house and we wired it electronically to be able to have video and audio, the audio through earbuds, but video and audio in all the main areas of the house. So all of the areas that were common areas, because what we determined is, if we could get families in this environment that were in a situation where the kids were at high risk from leaving the house, we thought that if we could wrap services around them, get them involved in this high level of care, and provide this real-time practice and modeling and redirection in that house, that we could keep these kids from needing to go to the higher level of care. Because what we saw in Oklahoma, especially where we were at, these kids were going away 2 hours, 3 hours, 4 hours away. The parents were not able to continue to be involved in the treatment. And so we knew that the outcomes were poor, because so we're going to come back to that in a little bit, but that's what we did. So we created this house. The outcomes are better than they show there. We've actually had around 20 families in there now, and we're still showing right now 100% of parents reporting increased hope up to 30 days following their stay, because that's what we're measuring right now. And then every one of them, 100% of the kids have remained in their house through the duration of this program. So not just during that 30 days, but right now to date, we've had no one access a higher level of care after going through this program. What we do when they leave the program, we give them an iPad that's equipped with that device. This is going to be another theme you're going to hear, because I said it's that unbridled access after a crisis also. So the family leaves with that 24-hour connection to face-to-face therapeutic services that can be that kind of soft landing or buffer against going back into crisis. Larry, I know you got stuff to add on this one.
Yeah, we're excited about the outcomes of this program. Now, that home that you're looking at, there's about a $495,000 build out with all the equipment and everything else. Really high level, high dollar cost to do it, but the outcomes are great. So what we've done is we've taken the same model now, and we are now going to be able to go. We'll have some more of these homes that will be built over our 12 counties. But one of the things that we're doing is taking that same model and actually taking the equipment into the family's home, if they will allow us to, and setting up the equipment in their home and sitting out in a vehicle or in their garage and monitoring and being able to give them feedback in their own home. A lot less cost than trying to build a home like this in all of our communities. However, not everybody will want you to come into their home, and not everybody's home would we want to go into. So basically, this program is, I call this a reset. I mean, when a family's reached a point to where they're no longer functioning at all, and the child is at very high risk of being placed outside the home, either into inpatient or into foster care, this is one solution, one of the concepts that we've come up with that we've had some really great success with and outcomes with. We're excited about it. We're excited about the future of it, being able to go into the actual consumer's home and set up the same concept as we're doing in this house. So you know, I look at it more of a reset, and I think that the families feel very hopeful after leaving there. And when they leave there, like I say, we do wraparound services in their home, and the iPad is there to assure them that if they go back into crisis, all they do is have to touch a button and we'll be right there, at least video, and then we'll send our mobile crisis team out if necessary and make sure that things are going well. So it is one of the many things that we're doing to keep people in the least restrictive environment. Next slide, please. So the thing that we had to come up with, I mean, we're not going to be able to treat with like 52 families during the year in this one home. However, we're going to do that times 9, and now we're talking about a lot of families when we start putting the video and stuff inside their home and build other homes. So so in the meantime, and always, it's not just in the meantime, we recognize that we had to have family assessment centers that were open 24/7. So a family would have a place to come and the police would have a place to bring a family, and a family would have a place to come versus the emergency room. Because like Josh said, once you get to the emergency room, all you're doing is traumatizing people more. And sometimes that wait could be 2 or 3 days before they could actually find placement in an inpatient unit is what we've experienced in Northeast Oklahoma and North Central Oklahoma. So the goal is to crisis stabilization and continued treatment in the least restrictive environment. We facilitate a placement if higher level of care is deemed appropriate. That way the police officer is not sitting in that emergency room waiting on a placement for that child for 2 to 3 days. And it really literally has been that long before some of them were at place before we had these. So now they're waiting with us, they're waiting in a family assessment center that's open 24/7. When the crisis is stabilized, the family is issued an iPad. equipped with a MyCare application, providing 24 access for additional crisis management services and access to the general outpatient services, as well as the wraparound that we're doing in their home. The outcomes, I mean, these numbers are different now because we just opened those 3 units very recently, but 15 children admitted to the Family Assessment Center, 11 were given a safety plan and sent back home with their family, along with the iPad. 9 out of that 11 was referred to Grand for continued outpatient services, and 2 of them were followed up by the tribal healthcare system because they were Native American. So you know, really, it's like we try these things and they turn out to be really great ways to keep people from escalating and from going and being placed outside their home. And that's really, if you look at our outcomes and what we're looking for, those are the type of outcomes that we're looking for, and families staying together and being able to continue their life and not being placed outside their home. Josh, I know you have some stuff to say about this.
When we were looking at this concept, we look at our responsibility as a provider when it comes to CCBHCs. We're treating both the people we serve, but we're also treating the communities. And so that means sometimes problems come to us in a different way. So how we knew we were dealing with an issue here is a lot of times when families were making it to the ERs looking for crisis, they were calling us from the ER. We were helping them find placement. Our staff were helping them look for adequate placement for higher levels of care. But see, by the time they were in touch with us, law enforcement were still there. So we had a law enforcement officer at an emergency department. So we had a family at an emergency department, usually for more than a few hours, okay? Because by the time they get a hold of us, they weren't having luck with what they were trying to accomplish because they thought they had it under control. So that means that we had a law enforcement off of the street, usually a few hours, maybe multiple shifts, and they were there at a hospital, taking up a hospital bed. So nobody was happy with us because they thought they were looking at us like, this is not our job, this is your job. What are you doing about this? So we were looking at multiple outcomes. So we started this family assessment center with the idea that we didn't want them to go to the emergency department, period. Had to be simpler. So when law enforcement officers or families can walk into this family assessment center, right? So as we start promoting this, we talked about it's a safe place. It's a safe place for them to get immediate assistance with live people that are there ready to assess and provide care. That's how we were able to have this 73% diversion rate, because it's not just a pass through to find placement. We're doing everything that we can do to divert that crisis and provide treatment in our general ways of providing treatment. So it's at our 24-hour facilities already. It's just staffed with the family support provider. That's the main person that are going to be interacting with, bringing in therapists, bringing in other nurses, other levels of staff, whatever we need to do. And so we've seen over 26 children come through now. So it's fairly new, but it's doing what we thought. Our hypothesis is being supported here because we're at about a 75% diversion right now. With those numbers increasing, it's hovering right there at that 75% diversion mark for us. And that's with them leaving with that other support. So sometimes we're talking philosophy. We're talking about Oklahoma. Oklahoma's a state having a philosophy of kind of what's needed to meet the needs of the communities and the families we serve. This is just that kind of example. It's that teamwork and that example that goes into it. Can we go on to the next slide, please? Now, we're talking about providing the opportunity for enhanced care before, during, and after a crisis. And we knew that the way that we had been doing treatment for a long time wasn't quite giving us that opportunity. And what we did was we made some pretty bold steps by kind of completely rearranging how we look at a therapist. All right. So we have a workforce shortage across the world. We know everybody's talking about it all the time, but we knew that we had to figure out how to do more with less. And so what we did was we kind of thought about the outcome we were looking for was this true management of the health outcomes of the people we serve. So this like bite-sized population level health management from our therapists, from the people that we look at as our main providers, our most competent staff. And what we did was we developed this position called an integrated team manager. And what it did was it created this hybrid position of a clinical therapist providing services. At the same time, they were managing 2 staff, a care coordinator and a family support provider, sometimes a behavioral health coach, depending on the need of the people we're serving, right? The need of the families. And what it did was it gave them this idea of this whole system as their resource, rather than before our therapists were looking at their own time and their own modalities they knew about as the resource they were having access to. It gave them the ability to orchestrate that treatment for our families before, during, and after a crisis to be able to help prevent families even going into crisis in the future. So we're going to see this awesome infographic on this next slide. Larry will talk through it, but we take the family as the nucleus and wrap everything that we have around it. And so we'll talk a little bit more about what that looks like. If it doesn't sound amazing, then I'm not doing it justice because when I'm just talking about team-based care, it's got to be cooler sounding than that to you, or I'm not saying it right. So I'm going to let Larry, if you want to go ahead and add on to that.
Yeah, you know, we've all talked about team-based care for years. We talked about the treatment plan being a team of people that come together and build a treatment plan, individualized treatment plan for someone, and then we follow that treatment plan. And we've talked about that for years and years. Well, one of the things that we knew that we had to do if we wanted to get outcomes is to build an outcome-based treatment plan. And it has to be a live treatment plan that is updated every time a progress note is done. And it has to be alive, and it has to be real, and it has to be what is actually happening in a client's life. And the team has to be part of that. The only way we could pull that off is by taking and renaming our therapists and having 50% of our time of our therapists doing integrated team manager and managing these two other staff and having a caseload that is not so large that you can actually get things done with them, and your documentation is good, and your continued support is good for the family, and so everything started being looked at as, what do we want the outcome to be? We start with the outcome in mind, and then we decide what the treatment needs to be to get that outcome, including physical health care, other type of dental care, whatever it may be, to get this outcome that we're really looking for this client. And then that integrated team manager pulls everything together. That care coordinator is a major piece of this, of course, and that family support provider is looking at the kid's school, at the kid's health, at the family's health, at the family's home, at the housing, everything that you can imagine that is important to keep a family in their own home. We're looking at that because the outcome that we started with in mind was to keep the family in the home, keep them out of foster care, and keep them out of inpatient care and residential treatment. So anything that it takes to do that, we opened it up and said that's what we need to do. And so with our outcome-based treatment plan, that's all spelled out in there. And then we are using our data to tell whether a client's getting better, worse, indifferent, what's going on. PHQ-9, all the things that are important to do assessments for families. We're doing those assessments and on a pretty regular basis to make sure that we're actually getting making some headway in the treatment that we're doing. We have today we have over 3,000 iPads issued to families equipped with the MyCare application, providing 24 access to additional crisis management services and access to our general outpatient services. We have system of care families have 3,867. That's when this slide came out, so it's more than that today. And we have wraparound families of 429. So this is very important to us. It is the core piece of what made us move from a service-based treatment plan to an outcome-based treatment plan. And so all these things were necessary, and I can't, it's complicated. I could take 4 hours or longer to talk about it, but it is a major piece of how we have shifted from a community mental health center and done a paradigm shift into a certified community mental health center. And these are all very important parts of that. All these things tie back to what Sheamekah was talking about earlier also. Next slide, please. This is if you put the client in the center, client being a family, client being the child, you have an ITM, care management, CPRSS, and family support specialist is right next to him, is doing most of the services for that individual, and making sure that that individual in that center is getting what they need to in order to stay in the home and to stay out of crisis. Then you have your occupational therapist, you have your RN, and you have your dietitian, all those health things to make sure that people are staying healthy. And then of course you have your provider for your prescription, and looking at the what all the things the provider does for the family. And then we have a board certified child psychiatrist. There's not a lot of those in the state of Oklahoma. They're kind of like unicorns. You hear about them, but you don't see them very often. However, we have one that looks at those really tough cases, making sure that the medication is right in line with what's going on with the child. Also, the providers looking at the family and seeing what kind of if they need medications. So if you look at that client-centered program, and then on the outside of it is your support team, and Josh will talk a lot more about that, but your clinical support and how we put all this together and how it all comes down and focuses on that one thing, and that is the child or the family. Go ahead, Josh.
Yeah, if I can just drive one point home, I think how to emphasize this is that last square Larry was talking about, the team support specialist position. So this was traditionally going to be somebody who's working in the front desk or in the front office, and they may have been running insurance. They may have been checking somebody into an appointment. They may have been checking to make sure that everything was okay with our medical records. But what we did was we took this concept of team-based care and even took it to that level. So now these team support specialists, they're a part of a group of teams. So really they work for about 10 teams of integrated team managers, and they're directly responsible for making sure that everything that's necessary really in the chart, but some of the bureaucratic type things that are taking place in that treatment are there and present for the client to receive or the family to receive the best care possible. So the people we're serving, so that there's no interruptions in care. All of those things that therapists maybe not trained to do or not like to do as much. And so even them taking this non-clinical position, and then they're being laser focused, because really it's 400 people that we serve, that they're laser focused on making sure everything is there so there's no interruptions of care. That's how far we took this team-based approach, all the way up, everybody. And then your lines of communication and care coordination are consistent all the way up. So we're seeing some really good outcomes when it comes to that. Also, a lot of good feedback. Can we go to the next slide, please? So really, this is what's next. We talked about a couple of them. We discussed words mean a lot. And if you really notice the second and third bullet point there, where it says Family Urgent Recovery Center and Family Structured Crisis Center, we didn't use the word child and we didn't use the word youth, because that's not who we're going to treat at the centers. We're going to treat the families. And really, it's kind of controversial because it's non-negotiable. The family is going to be there with their kids, and they're going to all receive treatment, because guess what? A lot of times the kid's not the problem, right? That's where we're at with this whole deal. And so they're going to come in. I know that we're kind of up against the time crunch. What I'm going to do is, I know Larry's going to talk about this last bullet point. I can tell because Sam got on. That means like hurry. So Larry, you want to talk about that last bullet point?
Well, actually, Josh, I think we have 15 minutes, but
questions. They're going to want to ask questions in the next 15 minutes.
Well, let's get through this then. The Enhanced Family Crisis Center Continuum is exactly what it is. It is a family crisis center. We're asking at least one of the family members or whoever's close to the child, that may be the grandmother, the grandfather, the father, the mother, but to come in with the family. If everybody refuses to come in with the family, then we will assign one of our staff to be a surrogate family member that will be there and advocate for that child while they're in the crisis center. And the Family Urgent Recovery Center is, we're building it out right now. And the Family Crisis Center we're building out right now. So both of those are being built out right now. We haven't got them open yet, but we've got the staff for it, and it's being finished. And the remodeling is going to allow families to come in 24/7 and be able to stay there in a bedroom with their family and be treated and see if we can get them back into the home. We also have the brief therapeutic home concept, as well as, of course, SOC, wraparound, all the other services that we're providing so the family can go home. One of the things that we're looking at is a dedicated network of therapeutic foster parents. We're looking at our staff, along with the Department of Human Services, to see if any of our staff want to be a temporary therapeutic foster parent for a child that the parents are just not willing to deal with right now until we can get the family back together and get to work with the family and then get the child back into the home. But we're looking at our staff because they are professionals. They understand this type of work, and so we're looking at them to see how many of those want to be therapeutic foster homes. And that's it. So I think we're within our timeline. Thank y'all very much, by the way. Everybody that's on here, thank you. And I think that we're going to open it up to questions. Matt, do you have that?
Actually, I do, Larry.
Okay. Okay.
Yeah. So this is for Larry and Josh. How are the iPads used? Excuse me. How are the iPads used in having immediate access for providers?
Yeah, it's one of the applications. So, but right now, we actually do utilize the application interagency. So it allows us to do a lot more with the providers that we do have. So we have 4 psychiatrists that work with us and 8 advanced practice providers. And so for us, we're able to utilize that same software, but we're really just utilizing it as a telehealth type software. So we're not doing, at this point, due to the need for vital signs and things like that being taken, we haven't figured out completely how to do those. We're trying really hard to figure out how to do the provider appointments while somebody's at their house, but we're not to that point quite yet, if that was your question. So we're using it to enhance our workforce, site to site, not while the client's at home or the family's at home receiving services from the provider. I don't even know if that was the question or not, but that's what I got to say.
So Josh, if I can help you with that, because technically these iPads are in the homes of children and families, and they can connect to grant staff only, not an external provider. Is that correct, Josh?
Yes, and if that was the question, I didn't even get close to it. So that is correct.
So not an extended network of providers, right?
No, that's not. It's a secure line, which makes it very beneficial to us because we know that it can. So right now it's a lockdown mode. There's only a connection to our staff who they have an ability to connect to, but nobody external. At the same time, they can't like stream videos or watch movies or do anything else on it either. It turns it into a mental health machine. That application turns it into a mental health device for that sole purpose.
Okay. Is the Family Assessment Center open 24/7, 365 days a year?
Yes, and we currently have 4 open.
Yeah, we have 4 open, and we're looking at 4 more. And it is walk in, ever how you want to come in, and never closes. There's always a family support specialist there minimum, and always access to therapists, RNs, and provider if needed.
Perfect. How is the Family Assessment Center different from a CSU?
A structured crisis center. Family Assessment Center is designed to do an assessment. I mean, we're really trying to figure out what the family's needs are and move them from the Family Assessment Center to meet those needs. That's why we're building the Family Crisis Center, the Family Urgent Care, and why we have the Brief Therapeutic Home. And we'll build out more as time goes on and allows, as we are able to do it. We can only move so fast. I would love to have it built out on all 12 counties right now, but we have it in 4 counties now, looking at 4 more over this next 12 months. And so, but the Family Crisis Center is if we can't get this client and the family stable enough to go back home with an iPad and wraparound services, then we would move them to our Family Crisis Center, which is located pretty well centered in our agency.
Yeah.
Thanks, Larry. Which MyCare app? There's several to choose from.
This is going to be go ahead, Larry.
Go ahead, Josh.
Just the client connection. So really how this would work is the family would have their version of the application, which would be the connections app that's client and patient specific. Then on our end, all of our providers have the other version. So the three versions that we work with are the law enforcement version, which is specific to law enforcement. And I misspoke earlier. It actually has two buttons. It has a button that Oklahoma worked with us on developing that actually gives law enforcement officers the ability to access care anytime, also to debrief from a tough stop or things like that. And then it connects to our crisis centers. The client app connects them to our service providers, not just the crisis centers, but also they can connect with our therapists and other levels of staff who have their own application that is specific to them.
Folks are interested in hearing about how the program is funded. Is the funding model different from these youth services versus adult services?
Oklahoma chose to be a PPS2 state when it came to funding on the CCBHC, and we're paid per member per month. And so our job is to get outcomes, not to necessarily see the client. Of course, you have to see the client to get paid that. But if you look at the three main staff that are assigned to 40 clients, that's really about 280 hours of direct time for the therapist working half-time therapy, and then the care coordinator and the family support specialist. And you divide that by 40, that's about an average of 7 hours per month per client. Some clients are going to maybe require 3 hours, where some other clients are going to require maybe 10 or 12, 14 hours, whatever it is. So they're able to take that, their time, and spread it out based upon the need of the client and who they're serving and what level of severity at crisis and what's going on in the family. So that's what makes it kind of nice to have a PPS2 model. It's not even related to a fee for service like the PPS1. You still, with the PPS1 model, you get paid for seeing the client, but you get paid for also for 1 day, seeing them once a day. In the PPS2 model, you're paid to get an outcome and whatever it takes to get that outcome. And Oklahoma did a great job with that. Thank you, Sheamekah, Jackie Shipp, Deborah Holgos, and all those great people that did that.
Thank you.
Sorry, Kelly, can I just
Sure.
jump in for those who might be on the line who are less familiar with CCBHC and the reimbursement model, which I think is probably where a lot of those questions are coming from. Larry, referring to that PPS2, that's that prospective payment that I talked about a little bit in the beginning. So the states participating in the Medicaid demonstration, or some who are operating in state plan amendments or waivers, that gives the clinics an opportunity to do costing, right? They develop a cost report that looks at all of the costs, not just fee-for-service reimbursement, but it takes them to implement the model, including innovations and indirect costs, right? Thinking about what their service delivery model looks like, moving more and more of those services maybe outside the traditional four walls of the clinic, what they can reimburse their staff in order to do that, and building it all into that cost report, and then getting an encounter-based rate that gets calculated from that. So that is, I think, one of the most critical things, the work that Grand has done. It's because you all have done, Larry, you were just rattling off all those numbers. You've done the work to really think about, what does it cost us? What does it take us operationally to do this differently? And how do we build that into that PPS so we can reimburse our staff differently, so that we can build in those other indirect costs?
I think what Oklahoma recognized is that we had to do something different if we wanted to get different results. I mean, and so it really freed us up to be able to do some creative things like the brief therapeutic home, like the family crisis center. I mean, I go on and on with creative concepts and ideas that we've had some great outcomes from, because we're really looking at what it takes to get the outcome, not serving the client, but actually getting an outcome for the client, which I'm sure other states are looking at that also. But it really moved us in that direction, and we had a lot of support from the Department of Mental Health and moving in that direction.
And that's really customizing services in order to meet the needs of children, youth, and families. That's really what that is.
Yeah, it's customizing and putting the services, building an outcome-based, individualized treatment plan, but having the resources and the programs to place these people in that treatment plan based upon their needs. It's all about individualized care.
Okay, we have time for a few more. Do you allow other agencies to come to Oklahoma and train with you all?
I think the person that asked that, go ahead, Sheamekah.
No, I said we get that all the time, and I think that there are scenarios that have allowed other states and other individuals to come to look at our models or to do ride-alongs with us in order to look at our MRSS model. So, but again, that can be taxing on our providers. So, Josh, I know you guys get that question a lot, and so I'll let you.
I think that the person that asked that is from Alabama, and interestingly enough, Larry and I are in Alabama this month talking to their provider network about some of this stuff to help them be prepared for the CCBHC rollout. So I don't know who you got to talk to get on the invite list for that, but that's your best bet.
Okay. How do system of care families differ from team-based and wraparound families?
So in the state of Oklahoma, our children's behavioral health network is our systems of care. So all children, really, we work with all of our children with their systems of care values and principles. So you may have kids that are at different levels of care and different levels of needs, which wraparound is our most intensive model that's operationalized within the systems of care. So really, our children's behavioral network is our systems of care, and it guides practice and it guides services for our families. And so those numbers will be a much larger number of families that we to wrap around. And as you heard Josh and Larry talk, they technically wrap around all of their families, but the model is only used for those families that are considered to be high end or high needs.
Thank you, Sheamekah. Are the iPad, sorry.
I'm not sure how to answer that question, except that systems of care is a best practice model, and it's something that we use through our whole system. Now, you're going to get, based upon your needs, your individual needs, that 7 hours that I talked about for that team to be able to use them on all 40 of their clients. That system of care is going to be more intense based upon the client's need than somebody that is maybe at that lower level is doing well. But we still use that model and we use all best practice models, and system of care is just one of the things that we put together and our therapists are making decisions about exactly what parts of that's going to be used on a given moment on a family. I think I don't know if I answered that right or not, there, Ms. Williams.
Yeah, that was fine, Larry.
But I mean, it is what we do. It is what we do.
Yes.
So
yeah,
it can't be wrong.
Thank you. I'll ask one last question. Are the iPads reimbursed by Medicaid?
No, the iPads are part of our cost report. And we purchased the iPad, the data plan, and the app from MyCare, and we give it to the client. And some people go, well, you've got to be, our clients are going to just tear those up. I'm amazed of how less we lose. We lose some iPads, but we can track our iPads no matter where they're at. Now, we don't do that unless one is lost or stolen. But we recouped iPads from pawn shops. But what you can't do is recoup an iPad from a bathtub or the bottom of the lake. And those are the ones that we lose. And so, but that loss is nothing compared to saving a life. If I have a thing about me, and it is, why do we exist? Why does Grant exist? And the bottom line, to save lives.
yes.
So what does that cost? It's cost reimbursed. It's PPS2 rate. Our cost is somewhere, when you look at a PPS1 rate, depending on how often you see the client or whether we're more expensive as a PPS1 than a PPS2, but it is a major part of our business. And we have about 14,000 iPads in clients' homes today. So you can imagine the cost of that, but the saving lives and it's keeping people out of the higher level of care. With adults, which we started this with adults in 2017, we had a 93% reduction in inpatient done by the National Research Institute, not by our numbers, but by theirs. So if you look at the savings, and that's what you have to look at when it comes to money. Are we keeping people out of the higher level of care because a $60,000 stay for a child in an inpatient unit versus an iPad is very cheap? I hope I answered that question to the best of my ability, but that's Josh, you got anything to add to that? No, we're out of time, aren't we?
I think Matt has one more question for you all.
Yeah, hi everyone. I'm Matt St. Pierre. I'm a director at the National Council. What a great presentation from our panelists. I had one question though. There was a trending kind of topic in the chat about staffing models, staffing funding. Just wondering if there's any last thoughts you could share about either how the PPS or anything else has helped you staff.
Yeah, I think it boils down to a couple different things. And so if you want to be able to recruit people and retain people, you have to pay them enough to get them to come to work for you. And you have to be able to compete with the people that want the same staff. It's a finite resource. And so the PPS models has given us the ability to pay a fair wage for people to come to work. The other thing that we've done is had to get creative with how we're going to provide incentives to individuals. So one example of what we've done in the last year is we created this incentive called Wellness Days. And really it's aimed at keeping people healthy, keeping our staff healthy, but happy also. So every other Friday, a certain level of staff and below. So anybody that's a director, below a director's level, they don't come to work. They get a wellness day every other Friday where they can take care of their business and they can handle the things that they need to handle. And so I'm gonna tell you the something you may be thinking, well, like we're in a workforce shortage and you're decreasing your workforce by 10% overall, right? So if I take that day away from them every other week, 10% reduction. So our hypothesis was that we would see an 11% increase in productivity the days they were there. Otherwise, it didn't work for us, right? And we did. We saw zero dip in productivity. We saw our retention rates right now. So first of all, I mean, listen, this make you mad, whatever. We don't see a staff force shortage right now. We don't see a workforce shortage because of what we're doing with our staff. So our retention rates right now are at a 90% rate, 89 point something. So if I round up, 90% is the best we've seen in years. And so we can point it to those two things right now. That's what we're pointing at.
And Josh, if I can add something, Grand is one of the agencies that maximize the utilization of peer supports. And what I mean by that, leveraging how those peer supports, not only through the hiring, but leveraging their ability to work with clients and also utilizing higher end levels of staff at the level that they're expected to work. And so really keeping and maintaining that opportunity to engage, keep people in services and driving them to the outcomes that they need.
Yeah, thank you. That's right.
All right, so we are definitely out of time now, but I would like to thank our presenters for sharing this awesome information. I am seeing great responses in the chat. So again, thank you. And thank you to everyone who joined us. And special thanks to SAMHSA for sponsoring this webinar. You all will get a copy of the recording and the slides. And please, when you log out, please take a moment to fill out the survey for us. Again, thank you all and enjoy the rest of your afternoon. Bye-bye.
Thank you.
Good to see everyone. Bye.
Take care.